Welcome back to the Ninja Nerd Podcast. Today we're talking about esophageal and gastric cancer. We're moving on through our oncology playlist one by one. We're getting there. I would say we're about halfway there.
It feels like it's forever.
Months have gone by. Yeah. No, it's a very involved system, and as we already know.
When you think about it, we're trying to cover oncology in a way that it's including almost multiple systems, and so you're kind of like going through multiple different systems, and unfortunately, the cancers that plague those organs. So yeah, it's a lot. There's a lot to talk about, but today I think we'll do a good job in talking about the esophageal and gastric cancer, which is it's really sad because these are oftentimes they're asymptomatic until the patient usually is getting towards like later stage or advanced stage, and that's usually when we catch it. So it's really important to be able to aware of the risk factors and any kind of like just subtle symptoms.
Yeah. All right. Well, let's get into it here. We have our first case. And we're going to be starting with, you're going to have to guess. I'm not going to give it away.
Don't give it away.
I'm not going to give it away. You guys are ninja nerds, though. You'll crack this case immediately.
Yeah.
All right, Zach. We have a 56-year-old man, 25-year GERD history. For 3 months, he's had progressive dysphagia.
This boy's been popping Tums.
Yeah, he's been on omeprazole his whole life.
Yeah. Half of his life. Almost half. Yeah.
So with his dysphagia, it started with solids first, having difficulty with solids. Now it's gone to some liquids, and he's had an unintentional 8-pound weight loss. There is no dysphagia, no bleeding.
All right. I mean, that definitely is concerning. I mean, obviously we're talking about cancer, so the big things to really think about when you think about esophageal cancer, there is 2 types. There is esophageal squamous cell carcinoma and esophageal adenocarcinoma. It's important to know location and also the risk factors associated with each. This one seems more like esophageal adenocarcinoma, which occurs in the lower third of the esophagus. Esophageal squamous cell is more upper 2/3. And so that one is usually associated with things like smoking, HPV, obesity. Those are usually really alcohol. Those are usually the very common ones. So if you think about squamous cell carcinomas, a lot of the time smoking is very heavily associated with it because a lot of the head and neck cancers are common with that one. HPV is big with it as well. And again, alcohol. With esophageal adenocarcinoma, that's lower third, that's very, very commonly associated with any person who has GERD, chronic GERD. So if you have obesity, if you have hiatal hernia, if you have some type of, I'd say, anything that can cause incompetency of the lower esophageal sphincter. So usually it's obesity. Usually it's just poor eating habits that are things that are going to trigger a lot of hydrochloric acid production. And on top of that, hiatal hernias. So those are really, really important things to think about. So that right there is making me think esophageal adenocarcinoma. And it's because of the GERD history. The dysphagia is really important. So whenever patients describe dysphagia, it's a difficulty in swallowing, right? And there's 2 different types. There's oropharyngeal. And the oropharyngeal is usually like, you can imagine this, if you swallow and you ever have a lot of coughing or you have nasal regurgitation, like you ever have like milk go up your nose or something like that. Yeah, things like that are usually associated more with oropharyngeal. That's things like ALS, that's things like Parkinson's, that's things like multiple sclerosis, strokes, things like that are more neurological in nature, that controls the upper part of the deglutition pathway. For this kind of a dysphagia, it's more esophageal. And it tells me that it could be structural, more so than functional. So functional dysphagia is like neuromuscular. Achalasia is a big one. Scleroderma, diffuse esophageal spasm. Those usually are going to be dysphagia that is not as progressive. And I think that's the big thing here. This one is a progressive dysphagia, and it's going from solids first, and then it's going to liquids. You can think about that structurally because let's say you have a tumor. Here's your lumen here, right? And then it starts off, I got to be careful with the finger.
Yeah, I was going to say, I wasn't sure what you were talking about.
Oh, we got to be careful
for
with
a second there.
Keep your minds clear, but just imagine here's the lumen. Imagine it only is occupying, the tumor's occupying like a quarter of the lumen, right? So it's earlier stage. Well, solids are going to be harder to get through that point. If the tumor gets bigger and now it's occupying, let's say, half or 3/4, now it's harder for liquids to get through. Yeah. So that's why it makes me think structural. So I would say the first thing is I always think barium swallows are just a quick way to go. They're probably not going to be the best because they're not going to tell me like if this is cancer, but it's at least going to give me an idea if I have a physical obstruction, and then I can go to an EGD. So that's probably what I'd start with first, is a barium swallow, just to give me an idea.
And then the unintentional weight loss just seems like an ominous finding where it's just a little scary, where
always bad.
Your mind just goes to cancer, unfortunately.
Yeah, I think that's the big one. And I think oftentimes when people develop cancer, it's usually weight loss. There's a couple exceptions. I think the biggest one is ovarian cancer, where they actually bulk up. They get like ascites.
Okay.
So they really bloat up, and their waist size goes up. But yeah, usually this is probably a combination of just the tumor always releases cytokines and causes like what they call cancer cachexia. So they just have cytokines that shut down their hypothalamus and their desire to eat. But also, if you're having difficulty swallowing, that also may have caused some food aversion as well.
Yeah, that makes sense. Yep.
So yeah, there's definitely a lot of things that scream cancer to this. I just think when you think about the type in this scenario, chronic GERD is a really bad thing. That's going to be more associated with lower one third of the esophagus. And then again, I think that the way that this dysphagia is described seems structural and esophageal-like, and then the unintentional weight loss is, like you said, is ominous. So I'd see if we can find a structural cause of the barium swallow and then go up with that.
All right. With the barium swallow, we do have a barium swallow test result here. It shows a long, irregular narrowing in the distal 6 centimeters of the esophagus.
Yeah.
So your suspicions are confirmed.
Yeah, so definitely there's something going on in the lower third. And again, I'm still concerned about esophageal adenocarcinoma. I think there could be other things like strictures. You could even have things like sometimes like esophageal, like rings and webs and stuff like that. You could have just a regular peptic stricture as well. So I think the best thing to do now is to get an EGD, because the EGD is going to give me visualization to see if I see like a friable, like fungating esophageal mass, and then also I can biopsy it, and that'll show me if it's like normal tissue, if it's what's called pre-malignant condition, pre-malignant tissue like Barrett's esophagus, or how is it actually said? Is it Barrett or Barrett's?
I don't know. You like to
I like to add S's on things.
Yeah, so for no apparent reason, he just makes things plural. I don't know.
Yeah, but that would be the best way to go, because it's going to tell you if it's truly like metaplastic or if it's like towards the end of dysplastic, or really it's a carcinoma at this point. So that's what I would do. I'd do an EGD, take a look, see if you can find it, and then biopsy it.
All right, so we have EGD with pathology here. It shows a friable ulcerated mass at the gastroesophageal junction. Biopsy result is invasive adenocarcinoma.
Yeah.
My next question, though, Zach, is now that you know this, where do you go next? Are you able to stage this now?
Yeah, you can. So I think the most important thing is esophageal cancer can spread distantly, but it's more local and regional that you got to worry about. So it can spread actually kind of to the bone, but mainly it's to the lymph nodes. And then what you have to really know is how deep in the esophagus it is. So it definitely can get into the blood and get into the lungs, right? It can go to the bones. I think it can go to the liver as well. But I think the big one is usually the lungs, and the bones are a pretty common one. But what I would want to know is how deep is it in the wall of the esophagus? And an EGD with biopsy doesn't really give you that answer as well, because we don't punch through all the way when we take a biopsy. So I would probably do an endoscopic ultrasound. And these are really fucking cool, because they come down, and then when they go down the esophagus, they go to the mass, and then you get a probe. It turns the ultrasound on, and it shows you, kind of imagine you're like in the lumen. It shows you the layers. Like you can see the mucosa. You can see the submucosa. You can see the muscularis externa. You can see the adventitia. And so the cool thing about that is that it can tell you how deep the tumor is actually extended. Is it just mucosal, so like what we call T1? Or is it past the mucosa into the muscularis externa? You can even see lymph nodes. Has it spread to a paraesophageal lymph node? The reason why that's important is it tells you if it's kind of like locally or regionally spread. And then from there, you can get a CT. Like if you have any concerns that they do have, especially if I see that it's invasive, like it's really going deep, I would probably get a CT. I'd probably do like a chest. That's a big one. You could probably add an abdomen and pelvis on as well.
Just because you can't rule out that it hasn't metastasized?
Yeah. So that's probably what I'd start with first, and see if it really has spread to anywhere else. I think the liver, the lungs, the bones, those are the pretty common ones. But yeah, the endoscopic ultrasound would probably be the way to go. Biopsy a node if I have them, if I see one. And then from there, I'd probably get a CT, chest, abdomen, pelvis, reflexively off of that.
All right, well, let's start off first with the endoscopic ultrasound. And quick question, if we're doing this another very invasive procedure, can we not combine this with the EGD?
You can.
Okay.
Yeah.
I'm like, why do you got to do this twice to this
it's actually pretty cool.
This poor guy, you're doing it twice.
So obviously after you do an EGD with biopsy, if you have a high suspicion, you could just chuck and just throw a different probe down. Because if they're already kind of intubated for the procedure.
They're already there.
Yep. You can definitely do that all in one fell swoop. Yep.
Yeah.
Just change it out to an ultrasound probe, and then you can take a biopsy if you need to.
Get both
while you're there. Absolutely.
Well, the endoscopic ultrasound, it does show that the tumor invades the muscularis propria.
Okay.
There are 2 paraesophageal nodes, and then fine needle aspirate is positive.
All right.
For our CT, we note that there is no liver or lung lesions. So at least it seems that it is local
not
for the most part.
Yeah, it's definitely a little bit more, it's deep. So, we're probably getting a little bit more, like if you're getting to the muscularis propria, that's unfortunate. But you're definitely deep, you're getting some nodes. So we're not far to the point of distant metastasis, but we have some local regional spread here. So I don't want you guys to go crazy worrying about like staging and stuff like that. It's not super commonly tested. I think it's just important to know, is it gone beyond the mucosa or is it not beyond the mucosa? That's really the reason why I say that, is because it guides your decision making of how you're going to treat these patients. If it's like not beyond the mucosa, we can sometimes just do like little endoscopic resections of that area, because you can just take that piece of diseased tissue out with an endoscopic resection. If it's only like mucosal involvement. If it's a little bit deeper where it's gone beyond the mucosa, then sometimes you have to go a little bit further. That's when you start talking about like, do I need to do chemo, radiation to shrink the tumor down enough that when I do a esophagectomy, I'm not removing too much? Because esophagectomies, they're not, I mean, you have to do what you have to do, but they don't always have the best outcomes. They're the thing that you unfortunately sometimes have to do, but the best way of being able to make sure that you have the best possible success with those is definitely shrinking it down. So if it's mucosa only, you can just resect it. If it's beyond that, you probably should shrink it down with like some chemoradiation prior, and then refer them to a surgeon for like an esophagectomy.
So had our patient been only mucosa only, it's fairly curative, correct?
Yeah. I think, and that's the hard part, is that, I mean, usually you don't catch these early.
Yeah.
They're like, this person was lucky that they weren't caught at like a distant stage. I mean, having symptoms, they probably had to have a pretty big mass to have symptoms. And that's usually the problem, is they start off really small. And usually these symptoms are kind of like not thought of too often. You kind of just like brush it off, like, whatever. And sometimes I feel like I have difficulties with probably because I eat food like way too fast.
I was gonna say you're taking down like 4 hot dogs.
Yeah, just glizzy after glizzy.
Yeah. But no, it does make sense when you think about it, in the fact that if it is small enough, you're right. You kind of just are like, no big deal, whatever. And then it gets to the point where you're like, wait a minute, I can't even drink my soda right now.
Yeah, that's usually the problem, is it's caught a little bit later. It's generally a lot of these cancers are pretty much asymptomatic until a little bit later. But this one was caught not too bad. I think that they're probably going to need some chemo radiation, and refer for an esophagectomy would probably be the best way to go.
So systemic chemo, like you said, try and shrink it as much as you can.
Yeah.
And then go for the procedure.
Yeah, I hit some radiation to the tumor, give them some chemo, and then go from there. Usually if it's distant mets, which thank the Lord it isn't for this one, usually it's just like chemo. And if they really are having symptoms, you can always palliatively put in like a stent and stuff like that, but there's not much you can do once it's metastasized.
All right. Case 2.
All right.
We have another patient here. This one now, we have a 63-year-old woman. Long-standing H. pylori gastritis. Now she has 6-week history of epigastric discomfort, early satiety, and a 12-pound unintentional weight loss. She notes dark stools twice now. So what are you thinking here?
So I
nothing good.
No. The thing with this one is, again, we know that whenever we're talking about these cancers, it's really trying to think about what would make me be concerned for gastric cancer, right? Obviously, you can have a differential off of this one. Like, they could just have peptic ulcer disease. It's definitely possible. The 12-pound weight loss, kind of unlikely.
Yeah.
But they're presenting with symptoms of dyspepsia. And so dyspepsia is kind of like, just imagine, it's not really pain. It can be pain, but it's more of like a discomfort kind of feeling, usually in the epigastric region, and it's associated with symptoms like nausea, maybe some vomiting sometimes, and just food aversion. You have satiety that's very quick. A lot of that could be due to a couple different things. Imagine usually these tumors, there's diffuse, which is not too common, and it usually starts like proximally, and I'm not kidding, it spreads throughout the stomach wall. That's less common. Intestinal type is the more common one. That usually forms near like the lesser, so you have the greater curvature and you have the lesser curvature. And so we go usually body, and then you kind of get down here as you get towards the end. I'm trying to draw this in the air, but you get to the pylorus. Usually where that lesser curvature in pylorus is where you can get a mass. You can get like a fungating mass there. And so that can kind of obstruct that outflow out of the stomach. So if you obstruct it a little bit, you can think about food staying in the stomach a little bit longer, distending the stomach a little bit longer, and that's going to be kind of like, imagine eating a bunch of food. You just take down like 4 hot dogs, a bucket of pierogies, and you put down a 2-liter Coke.
Sounds like a good picnic or something.
After that, you feel very uncomfortable, right? You feel nauseous, probably. You feel a lot of discomfort in that area, and you don't feel like eating anymore. It's kind of similar to that with these potential tumors, but also just the tumor itself, it may cause just near local irritation of like tissue and nerves. So
now it says here, long-standing history of H. pylori gastritis. Now, can't you have this be treated with a PPI and an antibiotic?
You can, yeah. So sometimes with H. pylori, it's difficult to eradicate. It kind of sometimes people can be on these and it just doesn't actually eradicate completely. And that's usually an unfortunate thing. So obviously you try to put them on things like a PPI. Usually they used to just do like clarithromycin, amoxicillin, PPI. They're kind of going to quadruple therapy now. Like metronidazole is a big one. Usually you can combine that with like potentially like amoxicillin.
Is that because it is so hard to eradicate?
Yeah, there's probably degrees of resistance and stuff with this one. But metronidazole is a pretty big one that we kind of add on to this one now. You can do like bismuth subsal, it's like Pepto-Bismol, PPIs, sometimes amoxicillin added onto that as well. But yeah, those are usually the kind of the things that we kind of treat this with. But sometimes it just, unfortunately, it can be hard to completely eradicate. And so you have different ways of being able to test and see if they have eradicated it, like the stool testing, stool antigen testing, the urea breath test and stuff like that. But unfortunately, this patient has had that. And with chronic inflammation comes the risk of chronic dysplasia. So anytime you have inflammation of a tissue, that tissue can unfortunately undergo mutations. When those mutations arise, dysplasia can occur. Dysplasia can then over time lead to carcinoma. So that's what makes me concerned about this is the H. pylori. Any kind of H. pylori chronically, autoimmune gastritis, which is kind of rare, but you definitely can see it. And you know what? They see this a lot in people who eat like foods that are, it's not good, salty foods. And that's where I am, baby. I'm living in the salty range, which is not great.
You sure
are. Salty foods and rich in nitrates. So like uncured meats, like hot dogs, glizzies and stuff like that.
We're talking a lot about hot dogs today.
But really high nitrate foods are really a high risk factor. Smoking is always a risk factor, but I think the big ones is H. pylori. Second one would be autoimmune gastritis, which they don't have that, and they usually are associated with things like thyroid disorders like Hashimoto's and sometimes even diabetes or vitiligo. But that'd be something you would think about. And then if they're having high salty and high nitrate, like rich diets. But this one seems like it's H. pylori related. They have dyspepsia, and then they have the ominous weight loss. The weight loss is probably cancer cachexia from the tumor releasing those cytokines. But it also is probably just because they feel discomfort and they don't have the desire to eat. They're satiated. Yeah. And that's probably an unfortunate thing here.
Now I have to ask about the dark stools. Is that because there's some potential bleeding in the stomach, and it's really the upper GI bleed?
Okay. Yeah. So esophageal cancer doesn't bleed too much. Gastric cancers will bleed.
Okay.
So it's kind of rare for esophageal cancers to bleed. So if it does, it's not good. But gastric cancers will definitely bleed. So that they're pretty fungating. They're exophytic, so they're pretty susceptible to bleeding. So the dark stools or melena would definitely make me be concerned about that. And I'd probably order like a CBC just to see if they have any chronic like blood loss in this scenario. If they only notice it twice, okay. But you can still have like unfortunately chronic anemia without having like visible like bloody stools or melanous stools. So yeah, I definitely would be concerned with this one. They got anemia. Probably from having this like blood loss. If not, either way, they have a GI bleed. That's super concerning. They have dyspepsia, they have weight loss. These are super, super scary. I'm going straight to an EGD. Like anytime a patient has dyspepsia, that's not an indication enough to just go to an EGD. We don't just do that on people like, oh, my belly, I got a sour belly,
Throw a tube down his throat.
Yeah. we don't do that. So if it's like they have dyspepsia and they have alarm symptoms, so weight loss is a big one. I'd say the early satiety, maybe even if they have nausea or vomiting, that'd be concerning. The GI bleed is super scary.
Yeah, I was gonna say her black stools are not good.
yeah, and some tar stools is not great. So yeah, from there I'd say we just go straight to an EGD. I have a high degree of suspicion of this being like gastric cancer.
Right, so EGD with biopsy. Same question I asked before. Can we opt for that ultrasound during this procedure?
Yeah.
If you think it warrants it.
Yeah, I'd say if I see a mass and it's like, all right, this is definitely an irregular appearing mass. It's because sometimes they can be flat, so they can be like sessile.
Yeah.
But this one I have a very like strong suspicion that it's going to be like a pretty nasty fungating like exophytic mass that's bleeding. So that's what I would do, and if I see that, I biopsy it, and then do an endoscopic ultrasound if you want to see if it's invaded, because you want to know if it's beyond mucosa, or if it's not.
Well, here's some information for you.
Hit me.
We have on EGD, we have our fungating ulcerative mass on the lesser curvature, kind of like what you were talking about. Biopsies show intestinal-type adenocarcinoma. While we're there, we talked about this. We switch out the probe for the ultrasound.
Yeah.
We also note there is a tumor into the submucosa.
All right.
And there are no suspicious local nodes.
All right. Well, they got that going. It's beyond the mucosa. It's into the submucosa, so it's a little bit of distance spread. It's not end of the world, but I don't think we can endoscopically resect it. So I think it's going to be a little bit more involved. But the other thing I would do is after we've kind of done this procedure is just make sure it didn't spread anywhere else. I don't think it has, given it's only in the submucosa.
Yep, that was my next part. Is we do that? Yeah, we're very thorough practitioners. We order a CT, the chest, abdomen, and pelvis for our metastatic survey.
Okay.
Nothing. CT's good. Liver's clear, and we note only focal thickening.
Okay.
And there really are no nodes greater than 1 centimeter.
All right, yeah, that's definitely a positive thing. I think that this is something that we could you could always talk with the surgeons and stuff like that, but I think an endoscopic resection, I don't know if it's going to be enough. I don't think that you'll get a good enough margin with that one, especially if it's into the submucosa, because you just can probably get a lot of bleeding with that. So I'd probably say at this point you probably need to talk to a surgeon and see if they're up for doing like maybe like a gastrectomy. Like you don't have to do a full one. You don't have to like fully remove the stomach, but I'd say like maybe a partial gastrectomy would definitely be the way to go. And if do they have any lymph nodes? You said no.
No.
So
pretty clear.
You can do lymph node dissection just in case you don't get all the margins clear. You can definitely remove some of those as well, just in case you have any like residual disease and you don't want it to spread to some nodes. So you could definitely do that. I would say at this point, just refer to a surgery, see if they would consider like a partial gastrectomy is what I would say, and then maybe removing a couple nodes while they're there. But that's what I would say. For this one, I think we have a pretty good overall prognosis. I'd say if it was like pretty far down and a little bit deeper and maybe they had some nodes, I probably would reach for like some prior to that, some chemoradiation, some neoadjuvant stuff. Yeah. But I think we're pretty good here that we don't need to do that. I think we've caught it a little bit early, and I think it's definitely possible you can get away with just a gastrectomy. If it was a little bit deeper, or it spread to, unfortunately other organs, then I think you got to go to the route of like just systemic chemotherapy. But we're not there. So I think that this one's definitely doable with a subtotal gastrectomy and maybe some lymph nodes cut out.
All right. That is all I had for both case 1 and case 2. I do want to just bother you real quick for a rapid recap. Okay. What I want to do for this rapid recap is as you're talking, I'm going to have a table pop up on screen so you can follow along as Zach goes through this whole thing.
All right. Well, I'd say like esophageal carcinoma, especially adeno, since that was in the case here.
Yeah, I would say like what's the two we're talking about?
Yeah, so esophageal adenocarcinoma, for that one, I'd say you really want to think about this one with chronic GERD. That's really the biggest thing. Obviously, if you have a patient who has chronic GERD, you've had an EGD in the past and they have Barrett or Barrett's, then that's another really big risk factor. There's a very high chance of Barrett's metaplasia turning into dysplasia and then cancer. A lot of these times the patients can be completely asymptomatic until they are not, and that's usually when they present with dysphagia. And again, the classic way is progressive. Solids, then liquids, usually. The things to get concerned about is like alarm symptoms. It's not common for these to bleed, but if they get bad enough that they're causing things like weight loss, nausea, vomiting, or they do happen to bleed, you don't want to wait for an EGD. Like, you don't want to go, oh, let's do a barium swallow, and then we'll... No. Go straight to an EGD. Otherwise, I'd say like a barium swallow is fine if they just have some progressive dysphagia. Just see if they have anything structural. If they do, get the EGD, biopsy it. While you're there, you see something, you're concerned, do an EUS, biopsy if you need to, any of the nodes. If you have concerns that it's distantly spreading, get some pan imaging, CT chest, ab, and pelvis. We'll probably do well for that one. And then based upon the results of these things, if it's mucosal only, you can probably just resect it. If it's beyond that, you probably have to start discussing esophagectomies. Depending upon the depth of that, especially if you get into the muscle layer, you're probably gonna have to shrink it down with some neoadjuvant chemoradiation, but that's something that can all be worked apart interdisciplinarily with your surgical team and your radiation oncology team. And that's something I would do for that one. For the gastric one, again, we're talking about the intestinal in this one. Diffuse one is very uncommon. The big thing to know for diffuse, just so you guys are listening, is if you hear the word signet ring sign on their biopsy, boom, it's diffuse. That's like the key terminology. It's a signet ring cells, and it's because they lose their EC adherence, but we won't go down that rabbit hole. Alarm symptoms for this one, or just in general symptoms, is dyspepsia. Just because someone has dyspepsia doesn't mean they need to get an EGD. If they have dyspepsia, that general epigastric discomfort, they have some associated satiety, maybe some nausea, but they got weight loss, they got nausea, vomiting, GI bleeds, pretty common with these ones. You got to go get the EGD. While you're there, you biopsy it. You can get pathology results. You can say, okay, let's do an EUS while we're there, see if we got some local regional spread, maybe some nodes, biopsy those if needed. And if you see some concerns that it is spreading, like if that just got mucosal, I probably don't need to get imaging. I probably don't need to get a CT, like a pan scan. But if I got, hey, this is definitely into the muscularis layer, all right, there's possibility it could have spread. Then you can go to that CT, chest, ab, pelv. But for these patients, depending upon how deep it is, if it's like near the mucosa, resect it, just endoscopically. But if it's beyond that, you can't really safely do that. So then you have to start reaching out to surgery, interdisciplinary with radiation oncology, and say, hey, can we do a gastrectomy? Maybe it's a partial. Depending upon the depth, maybe you have to do a total. And then from there, neoadjuvant chemoradiation is kind of just dependent upon how deep it is. Usually if you get to that muscular, you probably got to hit them with that. But that's kind of the things I would say for these patients. A lot of the times, if it gets too bad, whether it is metastatic, a lot of it is just systemic chemotherapy and palliative surgeries. If it's really, really bad, like they got consistent gastric outlet obstruction, put in a stent. If they have consistent difficulty with dysphagia, put in a stent. Otherwise, you don't really do anything except just trying to give palliative care. But that's what I would say is a kind of hopefully a quick recap for esophageal and gastric cancer.
Yeah, definitely a unfortunate cancer due to the asymptomatic presentation.
Yeah,
it just sort of all of a sudden, boom, it kind of hits, and that's a tough one to talk about. But it's great to have an idea of what to do, how to diagnose, how to treat.
Yeah.
So good episode.
Yeah, man. So I think it's just important to always know that a lot of cancers, unfortunately, do present asymptomatically, but if you can find these ones early, cut them out. That's the big thing. If they're a little bit deeper, there's still possible operations like esophagectomies and gastrectomies and things like that. But I really hope that this made sense, and I hope that you can take away from this something that can maybe spread awareness. Maybe if you get hit with some questions like this on your exam, maybe you get pimped on this about it while you're walking through the hospital from your attending or your resident, you're going to be able to answer these questions effectively because an engineer done hooked you up, all right? I hope that we did.
Yeah, big time.
I hope that you had fun. I know I did. I know Rob did. And man, I love you guys. I thank you guys. I hope you're having a great day. And as always, until next time.